Hi everyone, Felix here, Advanced Clinical Practitioner for Eden Clinic. We often talk about the finer intricacies of the manipulation of hormones and sometimes delve deeper into neurosteroid regulation, etc. Whilst the science geek in me loves that kind of stuff, I thought it might be useful to just dial things back to basics. So let's talk about the hypothalamic pituitary gonadal axis, or HPG axis, in a little more detail. Now, the HPG axis is the marvelous negative feedback system that, when working correctly, makes that incredibly complex pathway of steroidogenesis super simple for us. However, it's sensitive soul, the old HPG axis. It really doesn't like what we humans enjoy doing, like staying up all night, burning the candle at both ends, drinking, partying, indulging in, shall we say, risky behaviours. So how does it work? I think to understand that, it might be useful to have a diagram, because diagrams are always more easy to follow than spoken or written explanation. So here it is on screen. We start with the powerhouse of steroid production at the top, which is the pituitary gland. This sits within the diencephalon in the brain, and it is the anterior or front portion of the gland that is responsible for secreting our gonadotropins, more commonly referred to as luteinizing hormone, or LH, and follicle stimulating hormone, or FSH. Once secreted, these two chemical messengers will travel to the testicles via the portal bloodstream. These two hormones both have jobs that they want to do. There's emerging evidence and understanding that they don't do these jobs in isolation anymore, and they actually have a bit of a crossover or symbiosis with each other, a symbiotic relationship. Now, these two hormones are on a journey to meet up with two specialist types of cells within the testicles. So let's start with LH. LH's primary function is to travel to the Leydig cells of the testicles to tell them to produce testosterone, whilst FSH has the job of also travelling to the same destination, the testicles, but to hook up with the Sertoli cells. The Sertoli cells are primarily involved in the production of sperm, and this is called spermatogenesis. So, once the two hormones have found their respective target cells, the release of testosterone and the creation of sperm begins. So what happens next? Well, next, once the body recognises that the testosterone has been produced and reached a certain level, it then, via that negative feedback loop, will send a message to the pituitary gland to tell it to stop producing LH and FSH. Essentially, the brain says, yeah, we've got enough testosterone, take a break, everyone. So what happens when all of this goes wrong? Well, when this marvellous system goes faulty, the end result is testosterone deficiency or hypergonadism. Now, there are different types of hypergonadism. You have primary hypergonadism. This is where there is a physical problem with the Leydig cells. This can be through trauma, loss of a testicle through an orchidectomy, for example, or damage from surgical procedures or injury. Then we have secondary hypergonadism. This is essentially where there is a problem with the brain and the messaging system we discussed earlier. And tertiary hypergonadism isn't normally as common, but involves hypothalamic failure leading to dysregulation of another hormone called prolactin, which, when raised to high levels, will suppress the production of testosterone. Cause for this can be small tumours known as microadenomas of the pituitary gland, or they're otherwise known as prolactinomas, and they cause those prolactin levels to increase, and that decreases your testosterone simultaneously through very complicated progestogenic interactions. If you want more information on the types of hypergonadism, have a click on the video link just up in the top corner there. So, as we know, testosterone is a very complicated hormone. It doesn't remain in its original form entirely. The body will convert some of it into estradiol and dihydrotestosterone via the enzymes aromatase and 5-alpha reductase, respectively. Now, aromatase is an interesting one, as the more you have of this enzyme, the more of your precious testosterone that gets converted to estradiol. One thing that's a huge factor in this over-aromatization of testosterone to estradiol is adipose, or fat tissue. Fat is a substrate for aromatase. Put simply, the more excess fat you have, the more conversion of testosterone to estradiol there will be. And this is why diet and exercise are so important in life, and especially in the context of TRT. The remaining testosterone is then largely bound by two proteins produced by the liver, which are albumin and sex hormone binding globulin, or SHBG. These act as both a transport and buffer system, and if you believe the literature, take up approximately 98% of the testosterone produced, leaving us with just a remaining 2%, which gets released in a pulsatile manner throughout the day, which we refer to as free testosterone, which is why, for some patients, and not all, smaller, more frequent dosing regimes can help, as it's hypothesized that it more closely mimics natural physiology. Dosing and administration frequency are complicated, and this should not be done on an absolute basis in a dogmatic manner. I think it should really be done on a per-patient basis, because there's no one-size-fits-all for every human being. If you enjoyed this video, just a quick one, please hit like and subscribe, and make sure you hit that bell notification. I'll see you in the next one.